Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host for today, Kristen Rosenthal. Today's episode features pathology expert Dr. Colin Pritchard, Director of the Genetics and Solid Tumors Laboratory at the University of Washington Medical Center, and medical oncology expert Dr. Heather Cheng, Director of the Prostate Cancer Genetics Clinic at Fred Hutch Cancer Center. Together, they will discuss optimal biomarker testing to guide treatment decisions for patients with advanced prostate cancer. This episode is part of a larger educational program titled Biomarker Testing in Prostate Cancer, an Essential Component in Transforming Care. For more information on Dr. Pritchard and Dr. Cheng, along with a link to the complete program, including a CME-certified text module with a downloadable slide set and an infographic featuring a biomarker testing algorithm, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this topic.
Hi, everyone. My name is Heather Cheng. I'm an associate professor of medicine in the Division of Hematology and Oncology at the University of Washington and at the Fred Hutchinson Cancer Center in Seattle, Washington. And it's a great pleasure to be here today. I should also mention I'm a medical oncologist and specialize in prostate cancer and genetics. So the topic near and dear to my heart.
Yeah, Colin Pritchard, also at the University of Washington, professor in laboratory medicine and pathology. I'm a molecular pathologist. Also have a role in the Brotman Beatty Institute for Precision Medicine, and which is based in our system. And I co-direct the Genetics and Solid Tumors Lab that provides molecular oncology testing for our system.
Great. Allie, did you want to ask your first question?
Yeah, sure. Thanks so much for joining us today. I just kind of wanted to get an initial right sizing for everyone, because not everyone might be a prostate subspecialist, et cetera. Just to talk about broadly, maybe Colin, if you could talk to us about what is the landscape of testing that we're currently doing in prostate cancer. Is it done on early cancers, late cancers, metastatic cancers, locally advanced, et cetera? And what types of testing are now standard of care, and what does that mean for our patients?
Yeah, sure. So most of the testing, the vast majority in prostate cancer right now, the standard of care is done in the metastatic setting. There are some limited tests that are done in localized disease, mostly for risk stratification, but that's kind of outside of the purview of our very narrow topic on homologous recombination DNA repair. That's more for like expression profiles that can re-risk stratify you. But in terms of molecular testing and for homologous recombination DNA repair, it's almost entirely done in the metastatic setting. Now, that's for treatment. Increasingly, and Heather may speak to this later, there is germline testing done for these genes in the localized setting, particularly high-risk localized disease. But for treatment purposes, and when a pathologist or a typical pathologist gets involved, it's mostly metastatic.
Maybe I'll just add to that, which is, and that's the oncologist perspective, is stepping back, across oncology. Even in my time on faculty, we've really seen a lot of changes in terms of use of molecular testing and how it's driven cancer treatment, starting from, CML and so it in Gleevec, which I learned about like in medical school, and we had sort of lagged a little bit behind in prostate cancer. I mean, we've had great medications that treat advanced disease, which are really built on a foundation of suppressing testosterone. But we'd sort of been, at least I would say for myself, a little bit envious of like some of the other cancers, like lung cancer and colon cancer, where they had targeted treatments, and melanoma. And so now we get to use these targeted therapies in prostate cancer, which is really exciting. But it also means we get to partner with our pathology colleagues to make it happen.
Yeah. Well, thanks for that shout out. Yeah. And of course, know that patients are so pleased as well. I mean, yeah, definitely over my training, I've seen the change going from just really mainly surgical and hormonal therapy and really change a lot, especially in recent years. So congrats to the prostate cancer world. I'm a breast pathologist, so we were one of those early targeted therapy type cancers. I think breast and our non-solid tumor colleagues have been in that world for a while.
Yeah, exactly. And I think another point I'd make is that these typically new drugs tend to get introduced in the most advanced disease states, and once they're proven to be efficacious, they start moving earlier and earlier. So all of this discussion may become more relevant in the high-risk localized disease setting because some of these agents are moving into the pre-surgical, or what we call neoadjuvant space, prior to surgery, to try to improve surgical outcomes. They do this in breast cancer, but we're not quite there yet for prostate. We're getting there.
So at a really high level, can you guys provide an overview of the rationale behind targeting PARP in prostate cancer with alpha reductase inhibitor combinations? What makes this approach particularly promising in the current treatment landscape?
Yeah, maybe I can start with that. So I think I mentioned earlier that in advanced prostate cancer, really the backbone of treatment is on a class of drugs, or a strategy called androgen being another word for testosterone, androgen deprivation therapy, sometimes called ADT. And that inhibits the androgen receptor pathway. So we have a new class of drugs called androgen receptor signaling inhibitors or pathway inhibitors. And these are really very effective and have really improved survival for prostate cancer patients. And newer on the scene is the PARP inhibitors, which are drugs that work through a different mechanism. And Colin can comment further on them, but basically they leverage biological weakness of cancers that are missing activity of genes in the homologous recombination repair pathway. And most notably, that would be like BRCA1 or BRCA2. 2 is the most common that we see. But the drugs, the PARP inhibitors, can leverage that weakness because they block a different pathway that is upregulated to compensate from the absence of, like, let's say, BRCA2 or homologous recombination function. So you're essentially, what I tell my patients is, you're essentially further inhibiting a pathway that's already down. So if that's error prone, you're forcing more errors on in such a way that the cancer cell can't compensate, whereas healthy cells can compensate because they still have BRCA function, whereas the cancer cells don't. But Colin, do you want to add to that?
Yeah, sure. I mean, I think we can take a step back too. I mean, this is there are going to be some mixed audiences to talk about DNA repair pathways in general just a bit. I think it's relevant to this narrow topic. So homologous recombination DNA repair is one of maybe 7, 8 different DNA repair pathways in the cell, depending on how you define it. BRCA1 and BRCA2 are both genes that function in the homologous recombination DNA repair pathway. There are other, quote, HRR genes, a long tail, and we can talk about some of those others later too. When you're missing function of BRCA1 and 2, so if you have biallelic inactivating mechanism of both copies of the gene, then you have dysfunctional homologous recombination DNA repair. And then PARP inhibitors, the poly-ADP ribose polymerase inhibitors, act on actually on a different DNA repair pathway, but there's a synthetic lethality. That's the dogma anyway, that if you have the homologous recombination DNA repair deficiency and then the PARP hits the other pathway, the cell just can't handle it anymore. And so now there's this emerging literature that the androgen receptor inhibitors, the ARIs that Heather just referred to, that's the androgen receptor pathway, which is the primary driver of prostate cancer. But it turns out that there is some crosstalk between androgen receptor signaling and DNA repair pathways. So the idea is that maybe there's like double synthetic lethality. You know, so you've got homologous recombination DNA repair out, you got androgen receptor blocking, and then you hit both, and you get this it's like doubly synthetic. That's the way I think of it. Now that's still emerging and it's complicated, and I don't think the science is fully settled there. And I'd venture to say it's somewhat controversial. I mean, there's still there's large trials. I think we'll talk about them later that have come out, but there's still relatively early data in terms of how effective the strategy is, and then also what is the science behind the synthetic lethality is still emerging.
So among men with prostate cancer, what's the incidence of these types of mutations and their applicability to be able to take these types of drugs?
I can jump in first on that. in the metastatic setting specifically, so the incidence or prevalence, depending how you define it, of these mutations is different between metastatic setting and localized disease setting, because it turns out that probably having these mutations actually portends a worse prognosis, means you're more likely to get metastasis. Some of them actually can occur at the point of metastasis too, but I think it's more the case that when you have them in a localized disease setting, you're more likely to get metastasis, which is probably why they're more enriched. So in the metastatic setting, overall, if we lump together BRCA1, BRCA2, and this long tail of other HRR genes, maybe 20% overall, of which, again, specifically metastatic prostate cancer, of which about half of that is germline, inherited, and the other half is all somatic, right? So not, maybe 1 in 5. Heather might want to elaborate more. It's maybe even up to 25%, depending on how you define it.
I think the studies have varied, and some are around 25, but I think it's probably 20 to 30%.
But we're talking about, just to clarify, Heather, we're talking about only HRR, not mismatch repair. So if we only include HRR, that's what I was thinking. That's why I was subtracting 5%. But I think it, yes.
What proportion of those men have a germline BRCA mutation?
Well, Colin published on this, so I'll let him answer first.
Yeah, so sort of our claim. Well, Heather and I are both co-authors on a paper from a New England Journal paper from years back now in 2016, and many others did large studies back then too. And basically 5%, about 5% of men with metastatic prostate cancer have inherited pathogenic germline BRCA2 variants.
Kind of in the ballpark, or probably a little bit higher than we see in breast cancer, actually.
Yeah, and that was what we were surprised to see. The dogma at that point back in 2016 was that it was really rare. Like, people already knew that BRCA2 was a prostate cancer predisposition gene, and that if you had inherited BRCA2, you were likely to get prostate cancer. But what I was told is it's really rare, like maybe 1 or 2%, right, at the most. And that's true if you take all prostate cancer, but fortunately, only about 10% of men with prostate cancer ever get metastatic disease, right? So 90% of men is only localized, and they die usually with their prostate cancer, not of their prostate cancer, right? So, but if you focus just on that 10% that have metastatic disease, the prevalence is far, far higher. And I think that's why that signal was missed before. It really is substantially higher in the metastatic disease than in all prostate cancer, which again is, I think, pretty strong evidence that it's associated with worse prognosis, right? Because, you're born with this, and to see the prevalence that much higher in metastatic disease compared to men that only ever have localized disease kind of makes the point, right?
So we talk about the incidence, and we've talked about the mechanism of the PARP inhibitors. So is the mechanism similar for other cancers that PARP inhibitors are used in?
I think it's felt to be similar across, the cancers associated with homologous recombination deficiency. So that would be, BRCA2, BRCA1 related cancers, breast, ovarian, pancreas, probably similar, but there probably are some biological differences. But the main mechanism that Colin talked about is probably what we would expect to be at least partially sort of at play.
I'd like to delve into some key findings from some recent phase 3 randomized clinical trials. What are some of the significant outcomes that have emerged from these trials, particularly in terms of efficacy and safety profiles? Can you guys talk about that a little bit?
Yeah, I can probably give some background. And answer that question. So, because we know that, some 20% of people with metastatic prostate cancer have BRCA, let's just stick with BRCA2 and related cancers in the advanced disease setting. And we also knew that there were PARP inhibitors that were FDA approved for ovarian cancer and breast cancer. It seemed sort of, not too difficult to sort of see if those drugs were efficacious in prostate cancer in the setting, especially of BRCA2 and BRCA1 inactivation. And so the first 2 trials that were reported out were in 2020, and there was an approval for olaparib monotherapy in the very late stages of disease after using an androgen receptor pathway inhibitor. And then there was another drug called rucaparib, used by itself. And then more recently, I think there have been 3 studies. So the first one was Profound with olaparib. The second one was rucaparib, which is called Rubraca. And that study was Triton-2 that led to that approval. I'm not sure that we need to go into all the details of the design of each of them, but the more recent batch of trials, and there have been 3 large randomized phase 3 trials, have been a PARP inhibitor in combination with an androgen receptor pathway inhibitor. So specifically, there was a trial called Magnitude that is one PARP inhibitor called niraparib with another androgen receptor pathway inhibitor, abiraterone. That one, we can talk about the details and the outcomes, but basically that led to the FDA approval of that combination, niraparib plus abiraterone, acetate plus prednisone. So it's another option. And then there was the PROpel study, which is olaparib plus abiraterone for in the design of the trials was a little different. Some of them tested whether or not patients' cancers had HRR or evidence of homologous recombination deficiency, and some of them didn't, and some of them did not. So Magnitude did, PROpel did only after the fact, and then TALAPRO did use presence or absence of homologous recombination as a stratification factor. And that, in the case of TALAPRO-2, it was talazoparib plus enzalutamide, which is another drug. Basically, it's a PARP inhibitor in combination with an androgen receptor pathway inhibitor. And all 3 of those trials did lead to FDA approval. So they are in the toolbox for patients whose cancers have evidence of a homologous recombination repair gene mutation or inactivation.
So if I understand you, in one of the trials at least, there were some patients included that did not have an HRR mutation because it wasn't tested for upfront. Is that right?
All of them had some component of let's call them HR proficient cancers, but the design of the trials was a little bit different. So in the case of Magnitude, they were selected at the beginning, and then they were stratified into different cohorts based on whether they had at the beginning evidence of homologous recombination repair deficiency or proficiency. And then there was subsequent analysis in which they asked if we do an interim analysis, and does it look like there's efficacy or not? Does the combination look like it works better or not? And if it doesn't, then we're going to stop accruing to that arm. And they did not see a signal in the patients whose cancers did not have evidence of deficiency in homologous recombination. So in that group, that was stopped for futility. Only the people whose cancers had evidence of the mutation, was there a signal of effect, and so the FDA approval is only for people who have whose cancers have evidence of deficient homologous recombination repair deficiency. And then in the case of the other 2, PROpel and TALAPRO-2, they included all comers in the case of PROpel, and then and TALAPRO-2, and they asked the question, did they have evidence of HRR alteration after the fact? So the design was a little bit different because in one, they treated them and they analyzed them differently. And then in another one, they just did it after the fact, or the other 2, they kind of did it after the fact rather than sort of prospectively, so to speak.
And Kelly asked about safety, not just efficacy, but so combining the 2 types of drugs together, how are patients tolerating that?
Yeah, so they are all drugs that we use have side effects. And the PARP inhibitors do have side effects. We know how to manage them in medical oncology. You can dose reduce, you can provide other medications, but when we combine them, even though there may be benefit, especially for the people who have, let's say, BRCA1, BRCA2 mutations in their cancer, we do see an increased toxicity, meaning more side effects. And the big one is anemia. So the rates of needing a blood transfusion were higher. So that is a question that, as a medical oncologist, we have to think about, how is the patient doing? Is this something that is going to be really disruptive? Are the side effects manageable? And then do they have time, or is it going to be really challenging for them to get a blood transfusion? So that factors into decision making.
Yeah, as pathologists, we know blood transfusions are not are something, that you don't want to get unless you absolutely have to. And then, so if the patient is experiencing anemia, do you have to hold the medications until that's resolved?
Yeah, often we hold the medication, reduce the dose. We sometimes, then transfuse and then try to lower the dose. But yeah, it is something that is not infrequent with the PARP inhibitors. And then patients who have testosterone suppressing, ADT have baseline low blood counts because absence of testosterone is associated with kind of a low level anemia. So sometimes it is kind of a challenge. And then people from a quality of life standpoint do have more fatigue.
Yeah, absolutely. I guess let's change gears a little bit and talk about testing. So there's a lot of experience in testing, for instance, breast cancers, and a lot of initial work on how long fixation has to take place and all those different parameters that have been put forward, and recommendations are based on the earliest ones that came out really with breast cancer. So Colin, for prostate cancer testing, so for doing this type of testing in prostate cancer in order to determine whether our patients are eligible to receive these therapies, what is the algorithm? What are the considerations, and what types of tests are you running on these samples?
Yeah, I just want to echo Heather's comments earlier about how far ahead breast cancer is and than prostate. We're catching up here in terms of molecular testing. It would be my dream to have firm guidelines on formalin fixation times and conditions and all that, like we do for HER2 and so on and so forth in breast. But
I mean, if you don't do ER, PR, and HER2 on a tumor, it's like, what planet are you practicing on?
Exactly. We're probably going to have a pan-cancer HER2 indication coming up soon, so maybe that will extend it out to all the tumor types, including prostate. But yeah, I think you really hit the nail on the head. I mean, in terms of thinking about like what's important for testing, I mean, the pre-analytical piece is, as us as pathologists, we know how important that is, and this is mostly a pathologist and medical laboratory scientists and related audience. So kind of preaching to the choir here, I guess, with this audience. But most of the people who are thinking about these tests are medical oncologists and related providers, and for better or for worse, and I'd argue mostly for worse, pathologists at this point are not a huge part of this testing because most of the testing is centralized in a few reference laboratories, right? So there is increasing on-site testing programs, and particularly at major academic medical centers and comprehensive cancer centers. So, and that's increasing, it's going in the right direction. We're seeing more and more on-site services, even in the community practice setting for pathology. But right now in 2024, early 2024, we have to kind of recognize that most of this testing is being done in the commercial laboratory space, and pathologists aren't really a big part of it. And I think that's a problem. And one of the big problems is on the pre-analytical side, because it's garbage in, garbage out. So, setting aside the fixation conditions, there's not really firm guidelines on that yet, specifically for prostate. I think it's going to be the same considerations of molecular testing in any other setting. But there are guidelines for enriching for tumor content. So, most pathologists are sort of familiar with that, because even if they're sending out for testing, they'll often be asked to, circle a slide and circle where the tumor content is. It's called by a variety of things, tissue qualification. At the University of Washington and Fred Hutch, we call it, we have a whole section we're lucky to have a very large team of molecular pathologists, and we have a section called the Genetics Pre-Analytical Services section that has 4 faculty directors and dedicated staff. And we view this, and what I like to say is that someday in the future, there might even be a subspecialty pathology fellowship on GPS pathology,
Do a whole
on
podcast just on that.
Exactly. Yeah, exactly.
Honestly,
Go on and on and on. So it's very important. But to your point, though, there really aren't great guidances out there yet drilling down on this, and there needs to be. At the very least, I think for the few medical oncologists and related providers who may be in this audience, just recognizing how critical this is. It really is garbage in, garbage out. And for the pathologists in the audience, don't think of this as a throwaway thing. A lot of times it's just something that, I'm busy doing my practice, and I got to do this and you don't really get paid for it. That's it's another problem, right? So that's another thing we could get into in terms of what are the issues around current testing. There's not really any meaningful professional fee at any stage of the process, which is another reason why pathologists are not, I think, fully looped into this really emerging area of medicine as they should be. But in terms of the methodologies, I mean, next generation sequencing is really the mainstay methodology. That's we can get most of the biomarkers that are important with regards to homologous recombination DNA repair through an NGS test. And so we need to do, at the very least, full gene sequencing of BRCA1 and BRCA2, and ideally at least 5 or 6 or maybe 10 more related homologous recombination DNA repair genes to really get that full suite. Some of the on-label indications for some of those PARP inhibitors that Heather mentioned earlier have a long tail of homologous recombination DNA repair genes. I think one of the approvals has at least 12 genes that are on label. So at least that, I would say, is required. But the good news is, I mean, these NGS technology, that's easy, right, to do a panel that large. And I don't even like to call it next generation sequence anymore. It's just kind of sequencing. We've been next generation for the last let's see, it was invented in 2005, so we're now 19 years in. So is that really next generation? It's kind of this generation sequencing.
We've gotten there.
So we've gotten there, yeah.
The millennials of sequencing or something like that.
Sure.
Heather, tell all of your colleagues how important pathology is. Probably you guys understand at a large academic center. I think oftentimes the pathologists, from my experience, and oncologists work really well together. It's such a great dyad when you can have that team, and it's really what's best for the patient. I feel and I've also been in circumstances where you kind of have to cover everything, and it's just impossible. I mean, look at the depth of what you're saying. I mean, it's mind blowing, and you can't know that about very many individual organs. So just a shout out to that subspecialization and really what effect it has on our patients. And to what you're talking about, Colin, we hear a lot of our members talking about a lot of these tests getting ordered on the oncologist side, and pathology sort of an afterthought, and then people ordering from multiple different reference laboratories depending on the clinical group, et cetera. It can be extremely I want to say discombobulated, very scientific word. And in the end, errors can happen, and you're potentially not delivering the most optimal care. So shout out again to the choir that we're preaching to, that really driving these sorts of initiatives through the laboratory and having them handle the selection of reference laboratories, et cetera, and really putting together protocols for the send out is so important. So important.
And I totally agree. And I would say one step further. I mean, in the future, I really feel strongly that it should be a goal to bring this testing in-house, realizing that right now the reimbursement landscape is terrible. It's extremely expensive. It's not practical. So right now, for most, particularly community practice, but pathology practices, it is going to be selecting the reference lab, qualifying the specimens, like you're saying. But I think what I'd like to get our pathologist audience thinking about is not like this is forever going to be that it's going to be a send out reference lab thing. This really is, I think, an integral part of what we do, just like histology has been for the last 150 years. I think this will increasingly be an integral part, and not just for treatment, like we're talking about here, but for diagnosis, right? We're seeing that already, and I know we're getting a little off topic here, but it is a pathology audience. We're seeing this already in neuropathology. We're seeing it in dermatopathology, and to some extent in sarcomas, where molecular testing in these solid tumor settings is an absolutely critical part of the diagnosis. And there's every reason to think that that's going to be the case in prostate cancer and other GU malignancies in the future too, just like it will be in everything else. And so it just has to be on site eventually. It doesn't make any sense to be, we as pathologists need to be able to understand what's under the hood, understand how the assays work, have some role in bringing them up and validating them and interpreting the data if we really want to provide the optimal medical care.
Yeah. And I would completely agree and echo that. Actually, as a medical oncologist, I think if you have a better diagnosis and better taxonomy, then you're going to do a better job, with the whole picture, helping the patient with the best information that you can. And that's what we're trying to move towards, and with the targeted therapies, but we can't do it without pathology partnership.
You guys are teeing me up here for my next question. I want to talk about the common pitfalls and or challenges that should be addressed in the arena of accurately reporting and interpreting findings from these sorts of tests. Colin, can you talk about that a bit?
Yeah, I mean that it is teed up perfectly. I mean, I think
Oh, it's like we planned it this way.
I know it's almost like you are excellent moderators. Yeah. So I mean, we've kind of covered one of them. I mean, if we just start from the beginning, one of the big pitfalls in interpreting these tests is that we have very little knowledge about what any of this stuff means. I mean, we need to be honest about that. We have tons and tons of research that's high quality, and we know basic things like BRCA2 deficiency does predict PARP inhibitor response in metastatic prostate. Like, we know things like that in general, but broader than those kinds of like really key pieces of information that we understand, we don't know that much, and we don't know all these sort of inner variables. So the field is the knowledge base is new, and it's rapidly evolving, and that's a challenge for interpretation, right? Especially if you're trying to bake in some kind of automated thing. And then the second thing is what we were just talking about in the last kind of segment, is the issue of that this area of testing is mostly concentrated in reference labs as a send out. And so that's a huge problem for interpretation, because so much of the interpretation is clinical context dependent. What just basic things like, what sample am I using? Am I using the primary sample? Am I using a metastatic sample? Am I using a cell-free DNA sample? We can talk about cell-free DNA coming up too. But also, is this in the setting of patients already had a PARP inhibitor and maybe even looking for resistance mechanisms, these kinds of things. So ideally, if you're interpreting the test, you are a pathologist or related professional that's qualified, to be interpreting this. And importantly, you have access to the medical record of that patient. And even better, you're plugged in directly with the healthcare team that you're supporting, and you're all part of one team. That's the ideal situation. Right now, that's a challenge, because it is mostly, it's what I like to call is the throw over the fence problem, right? You have a specimen, you throw it over the fence to the commercial lab, they throw the result back over the fence. Typically, the pathologist has no role in interpreting it at all. And then maybe after the fact, a medical oncologist or related provider might reach out to maybe a colleague they know in their pathology group who has some molecular knowledge and say, hey, I got this commercial lab report. What do you think of this? And maybe it's even after they've already started treatment. So that's not really the best medical care, is it? So those are some big challenges. Now, I mean, we are working, and then again, I think just to emphasize the challenge with reimbursement, right? I think the core, like, why can't we do this? Well, we don't like to think about it that much, but it does come down to money. A lot of it. It's expensive to do this. It's hard to get reimbursed. The insurers have not made it easy for us. And then, to be fair to them, it is new. And so it's a new thing to be paying for, and it is expensive, but it's also standard of care and in guidelines. Yeah. And Heather might want to talk about some of those guidelines coming up about what is absolutely standard of care. But the insurance landscape, the reimbursement landscape is particularly bad in terms of a professional fee component. And, FDA is not making this easier for us either, because FDA views this all as they think of us as a widget, right? I'm a widget, Allie, you're a widget. We're all widgets. There's no practice of medicine here. We're just widgets, and we're talking about a medical device, and our interpretation is the medical device. And of course, we as pathologists don't think of ourselves that way. We kind of think, well, maybe there's a medicine aspect to this. So I think just kind of breaking out of that, even the way we're thinking about this as a lab test rigidly, rather than as what I like to call a diagnostic study, much more like a PET CT, or much more like reading out a resection. Yes, there's a lab testing component, but we all recognize that there's an important physician component too. So these are challenges, and we're going to need to have meaningful professional reimbursement and meaningful payment for the lab test before we're going to fix all this, right? But it's going to happen. It's going to happen. I'm optimistic, but these are major challenges to interpretation right now, because we just have our hands tied behind our back. We're throwing these specimens over the fence. Testing is being done in a semi-automated or fully automated way without knowledge of the often without knowledge of what's happening with the patient other than what was put on the requisition, thrown back to a medical oncologist who often tries to interpret that result without any input from an expert. It's a challenge for sure, but there are ways to work through that. And just one more point, let Heather respond to, is that molecular tumor boards are a nice way to handle that. Now, again, molecular tumor boards are multidisciplinary, typically involving molecular pathologists, medical oncologists, and allied professionals, like in prostate cancer, urologists, typically radiation oncology, et cetera. But we recognize that even molecular tumor boards, not all pathologists will, or not all people will have access to. And so even that is a challenge in a lot of places. But it's a nice way, if you are using a reference lab, thinking about having a molecular tumor board in a formal way to facilitate interpretation, and that multidisciplinary team approach is a great idea.
Great way to demonstrate value from the lab.
Exactly. Yeah, absolutely. And I can say, for, at our institution, we're lucky. Again, we're an academic medical center. We're at a comprehensive cancer center. So realizing that's not, the norm, but we're lucky that in that setting, we are able to have molecular tumor boards. And we even have, for the last 10 years, we've been doing a GU prostate cancer specific molecular tumor board monthly. And then we have 7 other cancer specific molecular tumor boards. So it can be done at academic medical centers. I think that's the kind of thing that, again, it's maybe not realistic all across the board, but it can be done. And it's fun for everybody.
You have fun there, Heather?
Yeah, actually, I was just thinking about, from the medical oncology perspective, I mean, I think it is, and I think our group in GU medical oncology and our cancer center more broadly have been so fortunate to have the sort of partnership of the molecular tumor boards and our molecular pathologists. And I think that really helps with the interpretation and then the applicability of the findings to the patient and getting them on the right trials. And we hadn't talked about yet, maybe we can talk about later, but things like, that trip up, I see a lot of people for second opinions in the community. They come to us and they just kind of want to weigh in. And I run a prostate cancer genetics clinic, so people come to talk about germline and somatic testing, and sometimes they already come with outside testing, and it can be kind of scary to see what people have done. A lot of times people have been treated based on what very obviously looks like CHIP, right? We know that ATM mutations and BRCA mutations can occur in non-cancer cells, and that's not on the radar of most people, because most of the time the medical oncologist is trying to stay on top of all of these new drugs that are approved. And so we're really excited about all of these new opportunities. And I think just having the PARP inhibitors and now the PARP combinations are really great to have to expand the toolbox. But I think if we're going to really realize the potential and do it well, we also have to be thoughtful about selecting the right patients, which means the test and the diagnostics have to be as high quality as the medications we're giving. And if we're kind of, whatever the weakest link is going to limit our ability to do that best, right? So being able to review the results with a pathologist is really helpful. Having clinical context is really important. I see a lot of people ordering circulating tumor DNA when the PSA is undetectable. When the cancer is quiet is not the best time to send those tests.
What are you going to do with the result when it comes back?
It's not, and it's true, and it's unrelated to the cancer. So I think that's a pitfall, and I see that being done. And I think with good intentions, those tests are ordered, and it sounds great because they can test to whatever X depth of sequencing, but you don't have cancer. It's not actually helpful. It's actually misleading. So.
Yeah, that's a great point, Heather. We maybe should go over some of the specific pitfalls on these NGS tests in different settings, because they come up so frequently. It's like, so Heather's pointing out, in the setting of circulating tumor DNA, or also known as liquid biopsy testing, 2 pitfalls. One, you're testing at the wrong time. I like to say it's just like you're putting the needle in and you miss the lesion. Like if the patient has no active cancer, there's no point in testing. Right. Garbage in, garbage out, right? But then the other problem is that this problem of interference with clonal hematopoiesis, that also known as CHIP, clonal hematopoiesis of indeterminate potential, which is both really, so these are mutations that occur in white blood cells. They accumulate with age, and inconveniently, they also get selected out by cytotoxic chemotherapy. So, okay, metastatic prostate cancer patient tend to be older. and tend to have had prior cytotoxic chemotherapy. So pretty much all of them have this in their blood. And inconveniently, the genes that get mutated in the white blood cells are the same genes that are on label for the PARP inhibitors. So this is a huge, huge problem, particularly with commercial assays that are algorithmic and are doing plasma-only testing and then reporting back, found an ATM mutation on label for PARP inhibitor, therefore use a PARP inhibitor. And it's not even the prostate cancer. So that's a major diagnostic error. And this is where pathologists can come in and do some education, like what Heather was saying. So that's a big, big pitfall in terms of interpretation, is a
blind interpretation of the test.
Yeah, it's a big, big problem. And it's getting better. The commercial labs are starting to recognize this. We and others have published on this problem for prostate cancer, but it's still a problem, unfortunately. In terms of the solid tumor setting, in terms of specific, going more less high level and more to specifics. The big ones the interpretation problems we get into is a tumor that is MSI high, microsatellite instability high, and hypermutated as a result of MSI, which does happen in prostate cancer, maybe up to 5% of the time in the metastatic setting. When you see a homologous recombination DNA repair mutation in that setting, like in BRCA1 or BRCA2, that is usually secondary to MSI and is a passenger and not a driver. So what I mean by that, I mean it's not really homologous recombination DNA repair deficient. Just because you have a pathogenic mutation in one of those genes doesn't mean you're going to respond to a PARP inhibitor. You have to have biallelic inactivation of the gene in order to get the PARP inhibitor sensitivity biomarker response, right? So so this is a very common pitfall. You have an MSI high case, you have this long laundry list of mutations because the tumor mutation burden is high because of MSI, and BRCA1 and BRCA2 are gigantic genes that have actual little microsatellites within them. So as a result of microsatellite instability, you get little subclonal frame shift mutations in BRCA1 and 2. These get picked up by commercial NGS assays. Algorithmic approach, see BRCA2 mutation, classify as pathogenic, say use PARP inhibitor. That's the extent of the thinking. And medical oncologists are just completely sitting ducks for this, right? There's no way they can figure this out without our help. So that's a major pitfall. Those are, I think, just to highlight a few kind of nitty gritty ones. Those are two of the big ones that come up.
So is MSI testing also standard of care in the metastatic setting for prostate cancer? Is everyone getting that?
I don't know if everyone is getting that, but it is also, there is an FDA approved label for that, and that is included in the recommendation for tumor sequencing for all patients with metastatic disease.
So it's just part of the NGS panel along with BRCA. So you're going to get, but I would think it would be dangerous to get then your HRR results without MSI results, because you wouldn't know, right? It's
correct. Yeah.
You always have to kind of get the both out of it.
A package assay, which is comprehensive NGS. Yeah.
Yeah. And the good news is most of the assays do report both. So you at least have some chance of teasing it out. But again, most oncologists, even at an academic medical center, most oncologists don't really get this unless they're, having, molecular pathologists bend their ear day in, day out.
Yeah, I'm learning a ton.
Why would they, right?
Yeah, right. Absolutely.
Yeah.
It's very
trying to keep track of all the new drug label that we have to do on our end. So yeah.
You're trying to keep your patients' blood counts up and keep them healthy and coming in and doing, there's a lot going on, and then we all play a role in it, right? So you're talking a lot about kind of multidisciplinary care and coordination, with your molecular tumor boards. You even have your specific prostate molecular tumor board. That's awesome. And then about this working together closely, pathologists and the oncologists, to interpret and prevent pitfalls in testing. Are there any other pearls from your experience in working in this multidisciplinary setting that you would give to our listeners about how to take better care of our patients and provide optimal testing?
I as a pathologist, my pearl, if there are pathologists out who are thinking about setting up your own internal program, really be humble and really listen to your medical oncology colleagues. And this is we're a service oriented field. I mean, all physicians are oriented to service of their patients, but we we are also oriented in service towards, whoever our primary physician colleagues who are using us. And it's not to minimize our role. Our roles are critical, but I think particularly traditional anatomic pathology it's so mature as a field, and we've been doing it, at least 150 years. And the technology is so mature and the protocols are so mature that I think there can be sometimes a loss of understanding that like I talked about before, we know relatively little about what we're doing here, if we're honest. It's a new field. It's important. We have to do it. But it's like if we just invented how to do histology 10 or 15 years ago. What would we know about how to classify tumors based on, okay, so we have the technology, we can make thin slices, we can stain them with H&E, but with only 10 years of knowledge, I mean, can you imagine how little we would know? We would know almost nothing. And that's what we know about genomic anatomy right now, almost nothing. We have the technology, and it doesn't mean we shouldn't do it. We need to do it. We all need to do it, but recognizing that and then listening to our colleagues and, and it's evolving so quickly. What do you need? What do you need in terms of your report? Not what do I want to say as a pathologist because that's what I think I should say because that's the way we've done it forever. But what do you really need to know to treat your patient? So that's that would be the one thing I'd say in terms of the multidisciplinary approach. And I can say, I lead our prostate molecular tumor board, and so I learn every month. Oh, you didn't like the way we said that? That didn't make any sense to you? You get that direct feedback, like, okay, we'll tweak it. We'll tweak, listen to your customer and tweak it, because ultimately the customer is the person who's then communicating to the patient. So if you're not serving your customer, you're not serving your patients. And so that's so it's a great opportunity in a multidisciplinary format for us to continue to improve our process. And again, because this is not mature, this is in its infancy. There's both a necessity to do that and a great opportunity, and it's also really exciting to be able to be developing things on, as they're emerging.
I love that.
Yeah, I would just add that all of that is more, and I would maybe reframe it a little instead of the customer and the sort of service provider, as we're colleagues and we're working together, right? And
True,
ultimately the goal in the end is to be able to get these new drugs and these new these new FDA approval, these targeted therapies to the right patients. And then, we can often in molecular tumor board give that back and say, this patient did amazingly well. And that's probably satisfying for the pathologist to hear too, right? Because we're a team. So just, I think strong connections between your colleagues will ultimately be more satisfying and rewarding and probably more likely to be accurate and hopeful.
Thank you very much, Dr. Pritchard and Dr. Cheng, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Biomarker Testing in Prostate Cancer, an essential component in transforming care, on the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.